to cut mine.
Fertility Docs uncensored site on all things fertility doctors around America. Conceive or just planning, you're here to guide you every step.
Hi, everyone. We're back with another episode. I'm one of your hosts, Fertility Center. And today, host and friends, Dr. Susan Center.
Hello, everyone.
Fertility Center of Los Angeles.
Hi.
And today, we're at an episode that was inspired by this week, and we're behind the scenes Retrieval. But before, what have you guys been up to this week?
Yes. And that's not really what I'm preparing hopes. And I have not killed with, but I was so proud. And I've got my 4 big pots every spring. And you know how they always like a couple of racks. So I'm like, okay, if I kill them, number one, I'm going to blame it on back. And number two, I'm not going to, but I got them. And they're sitting waiting to get dirt.
What's the growing season and like start planting stuff?
If we hadn't had that, I would have started planting in a couple.
Wow.
I mean, I was hanging out yesterday in the sun because it was just perfect weather for that. So we've got one growing season, late February, June, and then heat, except for the things that are really gorgeous yellow bells in my bed, 6 feet tall.
Oh, wow.
That I planted lastly destroyed in our snowstorm.
Yellow bells, we don't get them.
They're like a bush, huge, and then it has these that look like bells. But they can get giant.
And all the bells cluster together. Susan, I thought mine had all got that snow. We got a bigger snow 2 years ago, and everything. I mean, they looked, but they grew back, and so
the entire thing looks. Everything you can see is brown.
Just leave it alone.
Maybe the roots are still alive. Yeah, maybe
spiky troll head,
Yes.
That only around sticks. But it could picture later. But it's 6 feet now, and I didn't have to do any of that year. But my yellow bells came back.
Okay, so you didn't know?
I did trim it
to a stub, like you do?
No, not to a stub. I would say there was probably. I mean, there were plenty of little branches. The big spindly branches was much. Yeah, like little stick brush foot, a foot rather than you just have like a foot of branch, contained little thing. Chance to come back at least.
Texas, at least my part of Texas, is brown and yellow. Anybody who has any type of pole destroyed, like core, the trunk have survived. Everything is.
So, Susan, do you guys normally was talking about that in Los and peaches, lemons, and like tropical fruits and all that stuff?
Where we are, those things do. People who there's here. The right temperature, an hour south of us. Those
our citrus, a little lemon tree to see if I can do more. When I was growing up in just in our backyard, lemon tree. We had 4 or 5 trees where someone ate their citrus for the week. Saved a bunch of the seed. We had one tree that grew both lemons.
How does that work?
Graft something in, but I can maybe with blue eyes, and I'm like, I got a comp orange tree.
Plans, CRISPR or something.
Editing, yeah.
Telling Carrie that I'm kind of at our school, and he's very well respected. He's a master gardener. Went over to his house, and we from seeds and stuck. He's got this whole system where it has keeps on and 12 hours off and all the watering. But he ordered seed catalog, so varieties of tomatoes and they are. Key purples are my favorite. Some of those too. So anyway, it'd be the first time I've ever grown tomatoes. Probably this a year when I try a gardener, I can at least feel like I tomatoes. Yeah, they look really things you've ever seen. The Amish them a lot, and when I forget. And I wasn't going to buy heirloom tomatoes I've ever eaten. Bruised skin. They look purple on got really bad bruised skin. Tomatoes, they're just great. Just got all kinds of juice. So those are my favorite.
Nice.
So we've got our question of the day. Proceed on with that.
Oh, let me find it again. Here we go. Conceived for 2 years, unsuccessful, just no positive tests. His sperm's normal. My labs or hormones are all normal. Excited 9. Periods are 50 days, but I was not started on letrozole. Curious disorders that could be causing this, and typically seen with PCOS and on other types of ovulatory. So, Abby,
I tell patients that where there's a wide. We as physicians have tried to fit patients. Everybody really fits in this spot. I was just telling a patient earlier that my feeling PCOS or not, it's about every 30 days apart or less, 34 days. Then probably not ovulating. So whether you have PCOS or not, as long as you have a good egg, is really good. On some type of medicine along that have PCOS more consistently at a time, and figure out kind of when to have intercourse. And what do you think, Susan?
Well, you have to also remember OS is more than LH ratio, that it was diagnosed, but ovaries that appear polycystic, having irregular periods, signs of hyperandrogeneal type hormone, which can be things like increased hair, types of things. And just, I'm assuming that about like a thyroid disorder are ruled out that are periods. And with the AMH, I imagine an AMH of 9.
Lots of eggs there.
So you may not string of pearl sign. You probably have follicles on each ovary, which is bacteria. So it may not have told you that you have PCA, in fact have PCA.
There are some others as well, obscure, of not having a receptor because your receptors are damaged. Other screwball biochemical things that typically we don't really have a great, you can as far as our routine diagnostic, most people who come yesterday and for, all right, let's try this type of med and see if we really what we're doing is how can we get you pregnant this way possible and work we can along the way, X medicine, and don't see a response, change our approach. But most of the time, we're not going to really dilatory disorder diagnose. It's time consuming. What we do to get you pregnant. So it's kind of an uncensored from the academic, all of us, and really want to know exactly what they're doing and why they can't get pregnant internally. So I have XYZ and go right. And so that's why the reality is often so prohibitive. It's just not worth the times when you're looking to get pregnant of what we do. So,
all right. Well, I think that now we're going to switch gears and go to our topic of the day, and patient inspired. And I think so our topic is scenes in an egg retrieval. Often just kind of start out with the door on the day you're going to have your.
Absolutely. And I would like from clinic to chime in on some different day in the land of, unfortunately, when you first complain, it says, please call them and screen you. And you pass your COVID-19 question, really, you're probably going to go intake or waiting, where they may ask you initial identification that whoever's coming in is, there's when it comes to embryo transfer, we generally will have they'll generally show you your room, office. Each person has got post-op room. How you guys, Carrie and Abby?
We, before next year, we have people with a central changing area, and then they each have their own little, and so when you come in, we'll design your gown, duties, and then IV started for the best cost. So just prepare to order now, IV or Bloody Marys, whatever. So that's kind of how it's a private that people go their own dedicated space after.
So are there curtains in your location?
Next place is going to be wall.
Yeah, so same here. We have they're fairly small. They just fit in equipment. And once they change, that's when she kind of goes through explains to them kind of any kind of questions that they have, issues or any problems before they go back for the egg retrieval. If that happens, then basically once our embryologists are back, make sure that our lab is ready, are then rolled back their procedure.
So I would say at most places, before going to see your doctor, reproductive endocrinologist, going to meet with and that's probably a doctor you haven't met. They're going to kind of go through all of the questions, make sure you don't have any lung problems, any of them concerned about you having person during anesthesia. We're going to go through that and kind of lifts of anesthesia.
And just to clarify, so in surgical, you're on your bed and they roll. In our clinic, we actually, people just walk right across at the clinic. Mean that we roll you up
somersault.
It's rolling back, and that's what that means. So waiting room, procedure room, whatever your clinic.
You may or may not remember your medications.
What I always tell my patients, the best bartenders, and that they you will transition you that you're going to be on and sleep and comfy. Ask that you're breathing. Typically intubate people and they're using they're closely monitored, anesthetist, and monitored throughout. But anesthesia is just you are comfortable and you're happy. And also makes me happy which is key for what I
say too. I think patients get a little because everybody sort of has the impression, and I'm not asleep, or before I'm asleep, don't sleep. And in fact, physiologists are starting to put them, how are you feeling? And, and then all of a sudden speech record player that's going, and the people can sometimes mid talking, you won't have a tube down your throat to breathe, and not just amazing after we get done that they're like, well, wait a minute, it's over in a flash.
What I want to mention is that typically used during at the same type of, they have encountered surgeries like a laparoscopy. This may have a colonoscopy, check out somebody's colon to make sure colon cancer or something like that.
Not the colon prep. We will never come see us. I just want to.
Yes. But most people don't have problems with nausea with the air. The type of is different. It's and it's easy. It doesn't have effects.
The other thing to know, going to everybody worries about what am I going to do in general. Every so often, really, really funny because they'll come up with whatever that will come out. But that is most of the time people just quick back up without revealing secrets. So don't worry about them.
So kind of going through the from center to center, but your anesthesiologist is there, ensure your heart rate looks good during the would be there. Somebody who the tubes over, and there's usually a circulator who needs something, or if there's sometimes she'll hand a rheologist, and then the other rheologist, and if they're not physically Nashville, they're physically in the room. They're usually standing on the other side of so that we can very easily, hopefully contain a lot of eggs at them. What about you?
That's exactly who's an embryologist. Obviously, have a circulator, a scrubbed embryologist is right on the circulating the tubes from the embryologist.
Might float in and out in the practice. Using the practice, like residents, they will be in the room. It is a fertility practice to have any retrievals, specialized nature of what we do and skills that they need down the road. So infertility doc, particular about that, there's in those things. Unless you are at case, those are docs who are doing it. They're just earlier in there, and they always have an attending physician watching them to make sure that everything. But typically, that is not something you ever have to worry about because they have, if anything, something to prove, and so they're going to go for every last egg and then some.
And to be retrieval, we'll have an MD. If somebody's doing, you'll know who's going to be in the room. If we ever have anybody, a resident, for example, who just observes, and we always ask to make sure they're okay with it. And if the resident doesn't go in the room.
And that's really, it would be whoever.
So curious about the prep. What do you guys do? Patient positioned, and how does all that?
As you're asking that, I can ahead of patient was brought into the anesthesia was induced with that was prepped in dorsal
lithotomy position. What's that?
Exam position. Your legs are comfortable, that they're your places. We typically put area, and so for now, clean off the outer. We'll put a speculum in and clean on. Different practices to use betadine. Some use a practice like a combination of do the betadine. I will until everything turns is removed. Like when I was in training where it was all, and really either is reasonable. And that's something that is so second nature because if you put together the number of prepped in the thousands. And so we just prep that draping, which is drapes, which are the signals don't touch unless you are. It's odd to talk about in a fertility. Goal is to avoid sterility.
Different kind of sterile.
We make sure that it's totally covered in the blue drape, put in ultrasound or cover on it, look around to time and make sure there's nothing else approach. Do you guys do anything with your
we use mine. Mm-hmm. Thing is, and probably come once you put the ultrasound, see how does everything look through them right beforehand. So, don't complaters, but sometimes we end a little catheter to kind of just so that we make sure injured while we're.
Mm-hmm. And it also moves super full. It's harder to see the. So
we just use sterile fluid to clean, and I'm sure you guys probably do this, or at least in our practice, or get operation, and they also get eye retrieval because because the vagina has germs and through the wall of the vagina. And very, very rare for that to have that risk. Generally, our patient has the amount of in the preparation that helps as well.
At the time of surgery, beforehand per se, during the retrieval, has an endometrioma likely to prescribe some additional.
Endometrioma, Susan?
You have a cyst, which is where we're doing the egg retrieval. So blood rate, a good, and so there's a little bit of an increased risk. I tend to give a few, but that's for me to even do that.
Start the egg retrieval, our transdermal.
What's a transducer, Abby?
Probe that we put in your vagina for monitoring because, see a fertility doctor assume that we email exams with ultrasound. Most of the time, actually, it's done vaginal. It's the best way to see as you go through, probably you'll see your ultrasound, and that's exactly, there's no difference in terms. Unfortunately, I always tell patients, much easier if we could actually see the egg. We can't. Filled sac that contains the size of that, we have some idea of maybe how many eggs it will get until it's all over with. Probably go in every single one. You just never know. You never know how quick they're going to be. You may know that you were going to get. And so the egg retrieval goes down. And Carrie?
I have a question for both of you. What music do you listen to in the operating room?
I actually music in the operating room. I'm until I get my first players wearing the same thing. I am until I get 7 eggs in my. It's once I just have a good feeling that I'm at least one baby out of, once I get past 7, more conversations and relaxed.
I usually listen to now we have this gym. It's very relaxing, but every time I start to hear it why did I not bring some, but for the retrieval, I'm like Susan. I mean, once I get an egg or two, everything's going to be fine. A couple of different of those fluids out when I think I'm going to. And so sometimes I'll leave out, which is what we normally do, needle to try and coax the egg out. If I don't feel like fluid back in and kind of blow in.
Blow out as in blow it up like a bomb.
Just inflate it like a bull, go at it. Or when there's a really low egg, everything I can to try and get the egg. Carrie?
Oh, go ahead, Susan.
Dying to ask y'all. So do you collect the fluid? So a little bit different in different people. It can vary from clear to more kind of bloody. Okay. Please.
Oh yeah.
More because when they hand it off, our room's pretty dark and hold it up to the light and see if there's.
We're talking about floaties. We're actually staying in your soda.
Eggs.
We're seeing eggs and granulus on ultrasound. It comes out white particle floating in the follicular fluid that we just usually when it's giving us actually goes back to the embryo. Good chance of being.
That's what I was going to say. More importantly, the final call is the embryo. That tube is handed off to the embryologist, the embryology dish. And then they look and they can find the egg. And so kind of are waiting with bated breath, waiting for what the embryologist has to say in terms of. So Carrie, how about you?
So we do, y'all know we're nerds, ugliness. And so we've been working on for a couple of years here. Has been, we track what is for most centers, like the fluid and like ash, which is putting that extra meat eggs in, that some extra of that fluid. That way, just in case an egg is stuck to cream, in order to separate eggs and cream, we end up flushing whereas normally you would just pass off as each tube onto the next tube, move on to the next, separate for all of those. So alleviated some of my needs because I know I'm going to do at least 3 flushes. And oftentimes I wrote data for this particular, I need some wake up flushes in the O in each side just to know that they need to wake up and they need to come out. And so as a result, I oftentimes get a call back that egg. I've gotten an egg or not. And so that'll my intensity going forward or, flush 1.
Important question. As a flush of us that are flushers and there's flushers. So in flushing, and I don't do it to the extra 5 follicles. I need to give it. So tell me what you have a follicle one and that you have to flush again, get it out in the 2nd or 3rd flush.
So I would like to first of all about flushing. So when retrieval done, there are 2 that could be used. You could needle be used, or you can. Generally speaking, they're using a double loom, but apparently that is.
That's not years ago, but no, I just use.
So if I have somebody who has eggs, I will use that I can flush more easily, who has a lot of follicles. Now, if I'm so back to Abby's question. Now, I are more anxious flushes.
The doctor or the patient?
That's what I was going to say.
If the patient is accepted, it seems.
Susan?
It does sound like a rape. Since you need to make some sort of anxiety scale. It's like people who to hold on to their eggs a little bit more. And sometimes they come out really, I tend to thinking a certain number of flushes to get an egg out, they're going to take about the same variability from follicle to flushing. So that's my quick opinion, right?
And we could probably spend the founding of that theory and how, because I'm pretty sure eggs and follicles seen
diagnosis so have you figured out how to get the average egg out or people with 2nd and 3rd?
By the time you hit 3 flushes, there's a subset of patients where on 4, 5, and 6. And that is when we first, in order to make sure that we had one fall like 6, 9, 12, and that I pick up an egg after flush.
What you said about 3 flushes, that's the egg number. I usually say I'm going to flush. Found out over the years, if it doesn't come out. So that's kind of then I move on.
Yeah.
So, all right. Well, sorry, we digress. Sorry for our listeners.
Conditions of your operating rooms different than a standard OR.
That's a great question.
The room is generally the ultrasound on, lights on in the room. And so it's not like doing, but it does let us have there's usually like a that we use we're placing the speculums there. Decorated in any way, clinic room. I want you to feel as homey, very comfortable. In an operating room, they're generally decor per se. And so there's a lot of anesthesia carts, big cream color buzz, all these kind of bells and whistles just do their thing. I think things that you would notice.
Pressure environment too. So you can walk in and walk out because you don't like light. Particles floating in that you want them in an environment. I don't like you to wear perfume the day of the egg retrieval. We went And so,
even though there's no perfumes,
we don't have any kind of odor on the day of egg retrieval. So I think that's different than some other ORs. It's come out. So we've done the eggs next, Carrie.
So once they get handed off, a tube is full, handed off to the embryologist, typically working in an environment, oxygen tension, nitrogen, and CO2. Eggs are really particular. Embryologist is going to identify, and what happens from there is a whole other episode. But once all of I usually, people bleed, some people don't. Check and make sure that there's no little stitch or just pinch to, I always do one final, no internal bleeding. Usually I would say about 100 cc's. It's serous fluid from, or if it's just blood, nothing to worry about. Final check, I clean and take all the draping out of lithotomy, or once we have her out of position, anesthesiologist is typically cutting off levels, and they're making sure that levels are all good. Usually she starts, I would say 10, 15 minutes, pretty fast. And sometimes it's
So then she wrote, and what happens when she gets...
Generally, you kind of wake to kind of have fun. Usually around then, they're with you to kind of keep you company. They're there to help you if you're having issues with, generally they'll start you off to make sure you're tolerating. So you usually to some crackers or something. Well, after an hour or so, they're going to be ready.
And one important bodily function you can do is go to the bathroom. Every now and then, can't go to the bathroom, and some response that people have to pain room, and it's really rare but sometimes we might have to on a little water, and we have to have you drink more fluids. We like to make sure that you can urinate. And then generally, as far as Paul talking about this earlier, provide or tell you a Tylenol when you go home. It's narcotics in certain situations. It's just things that you can buy in relief. And then be interested to practice. But before you leave to go home, come in after they've done all of the tubes of fluid, and then they go back through all of it again, didn't miss any embryos. And so they'll tell you how many eggs that you have before you go home. Is that how you guys do it, Susan?
That day when I come back, I know that how time that I left the operating oncologist will give them leave. So I know you two are into where you patients and where you do their work 45 minutes away. So
I know that.
Yeah. So retrievals, and I have to drive, but I also have my clinic right down the hall and needed. She's available emergency or anything.
Same thing as you, Abby, where we'll doctor who lets them know, but we let them know how many eggs, and then the day after, how many eggs we got confirmed, and then how many fertilized. We typically have them come back about that everything is resolving as it should. That's necessary and part of, because we're control freaks and there's a lot out of it. So
another thing I want to mention, having gone through, I was really surprised at how much discomfort I had the next day. And it really, I did about 1,000 sit-ups and work, but it just felt really sore. To know is that once the egg retrieval, it takes you a couple of weeks full of eggs, and it's probably going to take to kind of get back down to normal again. Immediate acute pain, probably 4 hours after the egg retrieval, and really kind of the lasting display just from your ovaries still being enlarged, 2 weeks for that to kind of go away. I think that's kind of airy. Anything you want to add forgot to mention?
I think that's a pretty nice view of a lot of what you're wondering about, because you're asleep, a good idea of, what you have done. Period.
I would agree with that.
Audience, thanks for listening. Be sure to subscribe and love to hear from you.
You can also insert.com to schedule or submit any specific questions you have. And all question anonymously for Ask the Docs. The more embarrassing, the better. All
right. Well,
bye.
Bye, everybody.